Hello. I don't need to tell you how important hip fracture is as a clinical condition, but it's also an enormous opportunity for us to understand healthcare in general. Patients with hip fracture are easily identifiable. There's no need to define the condition. A hip fracture in the UK is the same as a hip fracture in any other country. And there's the potential to use this target individual of somebody frail with complex medical needs, passing through the complexity of hospital care as a way of examining how hospital services for frail and older people are configured in our country, and to learn from the same sort of individuals being looked after in other health care systems. And that's a fundamental principle underlying the Fragility Fracture Network, a whole gang of different individuals from different countries around the world with interest in the prevention and the management of fragility fracture. One of the things that they did was to develop a minimum common data set, a set of questions that were necessary if you were going to run a hip fracture audit. If you didn't ask these questions, your audit probably wouldn't give you a complete picture of what was going on for patients with hip fracture. There are a number of hip fracture audits around the world. I think there are 10 established national audits now. And when we looked at those back in 2017, we found that they were asking a total of 250 questions in those different audits asking different questions. Only 50 questions seem to be present in more than 3 of the audits. That's in spite of the fact that the FFN had defined a core data set of 32 questions that they felt were fundamental to the design of any audit. So things were very untidy, and as a result, if you start to try and pull together the data from individual audits around the world and try and make comparisons between them, it becomes extremely difficult to do so. We managed to write a paper back in 2017 which did that for the 8 audits that I've shown you. But the comparative data from those was largely made up of, well, we haven't got that from this country, these gaps in the data, which makes it very difficult to draw any really cohesive picture of how hip fracture care is organised in any one of those countries and benchmark it against what's going on elsewhere. And the aim of the project I'm talking about today is to look at how our current use of the original minimum common data set has evolved away from that in different audits around the world, so that no single audit is currently using the same audit data set as any other. We wanted to try and work out whether it was possible to put together a revised minimum common data set that would allow us to benchmark hospital care in different countries against each other. So to do that, we took the 10 established national hip fracture registries, and looked at the data that they were collecting, the approach that they were taking, and drew up a comparison of them. We tabulated all the questions each was asking, and we cross-referenced them against the 32 questions of the original minimum common data set. We identified those questions that were consistently used in most of the national audits and those that weren't. And then we used consensus methods to try and establish a revised minimum common data set. It produced very complicated answers. Of the 215 questions that we could find somewhere in one or other of the registries, the majority of them were not being used in very many of the audits. Only 3 questions, anesthetic grade, operation, and the date and time of surgery, were being used in all 10, and for the rest of the questions it was very different. That's probably most easily seen in this diagram. So for each of the 32 questions of the original minimum common data set, you can see how often they were being used. You can see that 5 questions are being used in just one of the audits, and only 3 questions were being used in all 10. We presented our findings at the Asia Pacific Fragility Fracture Network, and we proposed at that time that the 32 question data set could be refined down into just 20 or so questions, 22 questions that we felt you could not do without. But that there were additional questions, and a total of 10 of those, that would be useful in individual settings. And the benefit of doing this in the Asia Pacific FFN meeting was that we had the opportunity to talk both to developed countries with advanced healthcare systems like Australia and New Zealand, but also to some countries which hadn't got an established registry, and had much more limited healthcare systems in general. And we were therefore able to get a sense from different clinicians in different countries of how things might work. We got very good agreement over the indispensable core data set of 22 questions. There was less consensus over the questions that might or might not be useful, but then we're suggesting that these would only be something that might be selected by countries for whom they are appropriate. So you wouldn't expect the same degree of consensus from that. Having presented those questions, we then developed a draft version of the minimum common data set, which we took to the International FFN conference last September, and we used online feedback again to finalise the version I'm presenting today. And we managed to get all the questions and the fields defined for the minimum common data set onto this sheet of paper, which, as you can see, is too small for you to read. But to give you a sense of what's in there, there are 22 questions that are indispensable, in our opinion, if you're going to get a sense of how patients pass through hip fracture care pathway. And then there were 12 optional fields that we felt that hospitals and countries might wish to adopt because they're appropriate to their own situation. So, for example, the date and time of trauma causing a hip fracture is not something that we think is indispensable. And in the UK system, the time between falling and being admitted to hospital is relatively short, or it is if your ambulance service is able to cope. But in other countries, patients are having to raise the money to go to hospital, or in some countries, actually having to buy the implant to take the implant with them to hospital if they need surgery. So measuring the delay in surgery, and for many patients that delay extends throughout their pathway, they never get to hospital. Measuring that day would require an additional question. So we've built that into this optional extended data set. We hope that the way that we've designed this, the revision of the minimum contest data set will allow new countries to say, hang on, this is a small data set that we need to collect, and we'll have a hip fracture registry. We hope that because everybody will be collecting similar data, it'll be much easier to benchmark each other against, benchmark your hospital and your country against other hospitals and countries around the world. And by identifying the key aspects of care that are really fundamental to the quality of hip fracture service, we can start to develop standards, internationally accepted standards for hip fracture care that can be used to drive up the quality of care in different countries. Now, if you want to read more on this topic, there's a brilliant toolbox that's been developed by the Asia Pacific FFN, which takes you through all the aspects of the development of a hip fracture registry, and has been hugely useful to new countries that are starting to take on the idea of a registry. Thank you.